Are you eager to dive deep into the future of healthcare? I'm Jim Weiss, founder and chairman of Real Chemistry. Join me on my podcast, Get Real with the Chairman, where we connect the dots between healthcare innovators and the communities they serve. I'm here to simplify the complexity of today's healthcare landscape with some of the brightest minds in the industry. Tune in to hang with us on Health Podcast Network, Apple Podcasts, Spotify, or your favorite podcast platform, and start transforming your healthcare mojo today.
Hi, I'm Dr. Raj Sundar, a family physician and a community organizer. You're listening to Healthcare for Humans, the show dedicated to educating you on how to care for culturally diverse communities so you can be a better healer. This is about everything that you wish you knew to really care for the person in front of you, not just a body system. Let's learn together. You've probably been there before. You have the patient in front of you, a child. An interpreter's voice fills the room. The child's eyes moves between you and their parent, and you'd realize something is happening here. Something with trust, fear, and hope. Things that are quite big to describe or even articulate that no real textbook prepared you for. Today, we're going to talk about the reality of caring for newly arrived refugee and immigrant families. You'll hear from a pediatrician experienced in caring for refugees and her wisdom navigating cultural differences around nutrition and child development. And this episode is going to be a bit different from the usual. This was a webinar, so instead of our usual format, I'm weaving together clips with my own reflection. It's about those moments that made me stop the recording and think, this changes how I approach this work. And hopefully that's helpful for you too. Here's what you'll walk away with. A framework for first visits that go beyond medical history. Strategies for discussing topics like developmental delays without losing trust. Insights into the relationship between food, culture, and health. The work required to identify environmental health risks. And how persistent and genuine partnership really can create healing. This episode was originally aired in Switchboard, a resource for refugee resettlement professionals serving ORR eligible populations. And this is Dr. Anisa Ibrahim. She's an associate professor of pediatrics and the medical director at a pediatrics clinic here in Washington State. And I'll tell you, one of the fiercest advocate for community-focused work and partnerships, specifically those with medical or social complexity. First, we'll talk about the art of first encounters. Every day, families walk into clinics across the country carrying trauma, resilience, and even hope. The quality of their first encounters can determine whether they become partners in their care or disappear from our systems entirely, when they really believe after their first experience, maybe this isn't for them. What you're about to hear comes from a pediatrician who has spent years perfecting the art of first encounters. So listen to how she transforms that initial clinical visit into something much more profound. Here she is.
First and foremost, the biggest thing when welcoming a new immigrant or refugee into clinics is information. I spend a majority of that first visit really getting to know the family. And it might be jarring to them because they're coming to a medical facility. I tell them, I'm a pediatrician. I'm going to be your primary care doctor. They need an introduction to who I am and what I'm doing for them. Today, I'm going to ask you a lot of questions, and some of these are not going to be directly medical. They're not going to be directly about your child's medical illness or their general health. They're going to be a way for me to get to know your family. We really focus on what we call migration history, and that gives us a lot of information looking at what was the journey of this family, because two people can be from Iraq and go seek refuge in Turkey and come to the United States, and therefore their risk factors, the traumas they faced, the help that they might need once they're here could be wildly different. It helps us get to know a family's linguistic preferences. You might be from Eritrea, but your language of comfort might be Arabic. We need to know that. I use this first visit to ask about literacy. It's the first time I'm getting to know the family. It comes off as a very non-judgmental question when I say I ask all of my families, do you read or write in any language? A person can speak 6 languages and read or write in none of them, or they can speak 2 languages and read or write in only one of them. That's really critical information, both for community partners who are going to be giving a lot of information in newly arrived families, but also clinicians who are going to be speaking to families or pharmacists who are interacting with families, regardless of where they're from or their migration path, there is a hope for the future, but also grieving the loss of a life once had. Leaving home is not something that people take lightly, and it's not a decision that one just wakes and makes. The traumas might be different, but there are shared experiences in grieving a life that you lost. And then when they come here, there's so many expectations of them that I think it is really a time for partnership, understanding, support, and empathy for families. I'll say I feel like the first few visits in the clinic, we see families a little bit after they arrive, because I'm seeing medically complex children. I see them 4 weeks later because I know they'll be due for vaccines, and that's a great time to get the second set in. So much happens in 4 weeks, and it's a good time to check in on adjustment. How are things going? What did you not think to ask during that first visit that you're thinking about now? It allows them to see me another time that we can build trust. And then I see them 1 to 2 months later, depending on how complex they are, or longer if they're not complex. But so much of what I do in those first visits is really an introduction to the Western framework of medicine, right? I'm your primary care provider. I will be partnering with specialists. I might send you to a different hospital to see a specialist. We are going to be communicating, but it's not going to be me. I'm going to be bringing you in when your child is well. We are going to be bringing you in for well visits, which is not a concept that is understood. Here are the things that I'm looking at. Here are the things that I think are important. It's really good for me to see your child when they're well, but also support you when you're sick. We're going to be having shared decision making, right? Because some families are like, you American doctors are actually crazy. Why do you keep asking me what I think, right? I don't know this. So it's really a partnership of, you're an expert in your child. I might be an expert in pediatrics, but you're an expert in your child. I'm never going to give you an option when I think there's a clearly better option. It's not a trick game, but it's really thinking about, you're an expert in your child. What do you feel most comfortable? And that's where the shared decision making is. It's not I think most families are worried, if you give me a choice, what if I pick the wrong one? That's not what shared decision making is about. It's really about sharing our expertise and doing something we know we'll both feel comfortable moving forward. We also want to keep open communication. The last thing I want to do is tell you or your resettlement agency, here's the plan, and no one is comfortable with it, because then plans don't move forward, then they won't get done.
I think about that phrase that you heard, you're an expert in your child. It stopped me cold. How often do we, as healthcare providers or professionals, walk into a room assuming we hold all the expertise? In some ways, yes, that's why patients come to us. But this is about flipping that script entirely. It's about gathering medical history and mapping human journeys, and acknowledging the expertise that the patients hold. The migration history is also important here. Two families from the same country can have completely different trauma footprints, different languages of comfort, different paths to healing. We can't cookie cutter our care or say, you're from X country, so this probably happened to you. Because most of these episodes, we talked about how diverse those experiences can be in their own country, depending on what tribe you are, what language you speak, or when you came as a refugee or asylum seeker. Now, let's talk about something that seems straightforward, but is anything but nutrition. One of my favorite topics to talk about. But nutrition and weight in refugee families specifically. Listen to how complex this really gets.
The most common thing that we see is malnutrition. Malnutrition varies from obesity to wasting. Obesity is a form of malnutrition because it could be access only to foods that are unhealthy. But it could also be, for example, I had a family who, because they were internally displaced in Iraq, did not leave their home for 2 years. The kids did not leave home. So food would come into the house. They did not feel safe leaving. So all of the children were obese because they did not have anywhere to go. And whatever food they got is whatever they ate. We want patients and families to have a good relationship with food. Food is so important. Food is love. Food is how people are shared. So the conversation can be very touchy because some kids can come in obese and some kids can come in very wasted. We want to have some kind of sensitivity around that. And then we know that food access can be variable. So within the weight issue, it is very much a medical issue. If your child is chubby or, they have big cheeks and they have really adorable thighs, and that means that family has enough food. That family can put food on the table. They're healthy, come from a wealthier class. And then the other thing that I see happen is that children are malnourished overseas. And when they get here and the families have access to food, the parents say, by God, I will feed this child. I will give them everything that they have. So obesity is not necessarily looked at as a negative thing. I really try to focus on health and not numbers or physical appearance. So I do an introduction to kind of like the growth chart, right? The American growth charts were not based on a diverse subset of people. These percentiles were not created to represent people globally. They were created to represent the children in America. The way in which I approach that is really slow and steady. I will talk about where the child is. I will talk about how access to food, but also access to physical activity has changed significantly. So, feeding your child is one of the most personal things that a family can do. I partner with them saying, I want your child to be healthy. Here's an example of things that would be healthy and well balanced for them. Often the access we have to foods that are least expensive are also not good for your health. As clinicians, people and service workers, we really have to think about what limitations families have, right? I can sit in my chair all day and talk about please eat fresh fruits and vegetables, but the reality is they might not have access to those foods. They are probably shopping at a grocery store where it's easier to shop in the center aisles with packages and preserved foods. It's not fair for us to say you should really be eating fresh fruits and vegetables if we're not giving them any kind of support to be able to do that. And then the other mistake that I think I have seen is that we recommend things that are not culturally appropriate. My grandmother, who had diabetes and lived in Somalia and Italy for all of her life, they'd come here and she'd say, oh yeah, they told me to eat broccoli again. She's like, I'm not doing that. That's not my cultural food. I say, yes, doctor, and I walk out and I do what I want. So I often ask, what foods do you eat? What foods do you frequent? Then talk about portions and what could make that food healthy, because cultural foods are really important. I think we will lose our audience and our partnership with families if we're recommending foods that are not cultural. I've had many people ask me, what is America's obsession with peanut butter? Like, why do we discuss peanut butter so much? We're thinking about high calorie food. Your child needs to gain weight. Let's do peanut butter. But if that's not something that a family eats, that's not something that they're going to incorporate in their diet. So it's having that discussion as well. And then over time, I start to think about activity, because we want you to eat healthy food. I move on to age-matched peers and why I want this child to have a BMI that is lower so that they can be healthier later on in life. And I think this topic overall is just getting to be even more sensitive, because we don't want to fat shame. We don't want to have children focused on their bodies, because we know that girls as young as 6 are already getting messaging. You should be thin. Your body should look this way. And boys are starting to do the same thing. So we want it overall to be a positive discussion that really focuses on their health and well-being.
So what hit me the hardest with this was that food is love. Food is how people really share. Think about a parent who watched their child waste away. I don't know how else to say it, but if you have children or feel close to children that's in your life, imagine seeing that, who maybe had their food rationed. And you had to ration food yourself so the child could eat. Now that parent has access to food, finally, and we're telling them that their child is gaining too much weight. Yeah, the clinical data matters, but the emotional part of this matters even more. And that grandmother refusing broccoli, we've talked about this before too, because I laughed out loud because so many people have said this. Why do we love broccoli and recommending it? And the idea, they say, yes, doctor, then walking out to do exactly what feels right culturally. We lose our audience exactly in that moment when we ignore their food traditions. So learn about those food traditions and be cognizant about what you're recommending. The next segment about mental health and developmental concerns. These are the elephants in many exam rooms. And here's how she navigates these sensitive territories.
2 others that come up often in families are developmental delay and mental health concerns. So often it is something that I try to not push on a family in that first visit when they're just meeting me, unless it's information that the family has said is important. Developmental delay and mental health are both highly stigmatized in many societies, and in many different cultures. There are not a lot of options for either treatment or support, or there's no framework for the importance of therapies or support. So families are not willing to just let someone know about this particular issue because they want to protect their child, which is very reasonable. Sometimes I will see that a child might have speech delay. I will ask a family, are you concerned about your child's well-being or development? And if they say no, that is really not the time, the first time you're meeting someone, to say, well, I think your child is not speaking, because they don't know you. They just met you. They're in a completely different environment. They don't know if they trust you. So I will often kind of say that for the next visit as we talk about our approach to care and the framework for Western medicine. Developmental is something that needs a framework of discussion for families, because most of the world does not follow milestones in the way that we do here in the West. We are very used to thinking about a child should sit at this age, a child should talk at this age, a child should walk at this age, where many of the world's cultures really believe that a child has their own pathway to growth and development, and it will be a long time before they say that kid probably has some kind of delay. So I don't discuss delays until I've discussed what we consider generally normal. As a pediatrician, even at 12 months, I can start to diagnose speech delay. At this age, your child should be saying this many words. Right around 9 months, we expect children to be babbling and imitating. If they're not doing that, can be considered a form of delay. They should be responding to their name. And then around 12 months, they should have a couple of words, and that increases exponentially. You can diagnose speech delay at a very young age. However, we have to establish normal and normalize looking at milestones and the variability of milestones for a family before we can say your child is delayed. Often I will have the discussion and say, your child is 2. I expect him to be saying many words and using 2-word sentences. What have you observed? Do you think he's doing the same things as the other 2-year-old in your family? And that's a very good comparison, because then they can say, well, his cousin is doing this where he is not. And it doesn't make it as scary because they have something to compare that to. And then I really focus on allowing this child to thrive and communicate, because children, they're smart. They have a lot to say. And the worst thing is a child who has something to say and cannot say it. So getting that support for them as early as possible and not making it a very touchy subject. I think that often if we push too hard, right? Because this is a family that probably did not have access to speech services wherever they came from. They don't have continuous access to it. They don't have a framework for if this therapy is going to be benefiting them. And the way that we describe speech therapy is someone's going to talk to your child and get them to try to talk. Many families will say, I just got here. I need to find a job. I need to be financially independent. I need to figure out a way to pay my rent. I don't have time for somebody to talk to my child. I could talk to my child because they don't know the skills of a speech therapist. Often it's really partnering with them and telling them, this is what's actually going to happen. This is a framework for what this therapy is for. This is what we are trying to do. And this is the goals that we're trying to achieve. So that's the approach to speech therapy and speech delay. But I think therapy in general, whether it's physical therapy, speech therapy, occupational therapy, all of that is a completely new framework for many people. So it's really what you're asking me to do fit within this framework of me trying to live and survive this new country.
I want you to hear the restraint here. If they say no, that is really not the time to say, well, I think your child is not speaking. This is wisdom at its finest, knowing when to hold back, when to plant seeds, when to trust, when to let trust build before diving into potentially stigmatizing topics. The milestone conversation, which sometimes doesn't feel stigmatizing compared to other topics we talk about, drugs, alcohol, sex, but it can't be. We're so focused on our Western developmental markers, but many cultures trust that their children find their own rhythm. Now let's shift to something that might surprise you. Elevated lead levels in our newest Americans. It's almost like a detective story.
Because of the newest wave of migration, especially with people coming from Afghanistan, we have seen elevated blood lead levels. Elevated blood lead levels really takes a lot of folks and helping outside of just the pediatrician's office. As a part of the new immigrant screening labs, lead should always be in there, whether they're coming from a high-risk country or not. Lead is something that I test for in every child that walks through my clinic if they're of an appropriate age, because it's one of those things where if it's in your blood, I don't want to miss it. Some people will say, well, this person's high risk, this person's low risk. And my approach is if I have a 12-month-old in front of me and I'm getting iron deficiency anemia screening labs, I can throw in a lead in there and I can check it off the list because it's something that you absolutely do not want to miss. I think the concept of lead and what it is, where it come from, et cetera, is something that requires partnership and teaching with families. And we have seen it a lot in our Afghan patients where sometimes the lead level will be a little bit high, right? I'll always encourage people to look at the CDC website for what is an elevated blood lead level. At what point is it reportable? At what point should we be getting follow-up labs and what kind of teaching needs to happen? For families who have elevated blood lead levels, I'm not sure if this is the case for other states or in Canada. It's a reportable condition, so we report it to the state. We also have a public health nursing team that do a home visit, because we can ask the family many things. Lead is most often found in spices and food that is imported. It can be in pottery, glaze, plates, etc. But sometimes families are not able to recall every single thing they have in their house. They just traveled here. So having that public health nurse go out, do some teaching around that is really important. I'm always a proponent for rechecking. I think it's very easy to assume that the blood level was, let's say 5, right? Not very high, but they came from Afghanistan and now they're in America. They're going to be fine. I don't think you can assume that. You don't know what the family has brought with them. You don't know where they're shopping. You don't know what other exposures they have. So the last thing you want to do is assume it's going to just go down on its own, because we have seen many people who can have consistently elevated blood levels, or some that were actually even going up. For example, in Washington State, a public health found out that there were pressure cookers that many Afghan families were either brought with them or they're buying locally or seeping lead. If we had assumed that the blood level was high because they were in Afghanistan and now they're fine because they're in the United States, we wouldn't have rechecked. But the blood levels were not going down. We kept checking and they were not going down. And we found that there was these pressure cookers in the county. Many of these families said, I got that off of Amazon. I got that from my local Afghan grocery store. And that was the actual source. It's something to really keep a key eye on, to recheck unless it completely normalized. No amount of lead is normal in a child's blood. So we're going to keep checking and rechecking and making sure that this child has no ongoing exposures. And even at very low levels, lead can be dangerous for children, right? Even if it's not at these high toxicity levels that need chelation or medical treatment, it can lead to IQ loss, learning difficulties, poor school performance, all things that we don't want for children and families.
Wow, can you believe that? Pressure cookers from Amazon. How specific and how much expertise is there? Here's a family trying to maintain their cultural cooking traditions, buying what they think is safe equipment, and then unknowingly ingesting too much lead. This is why things like public health nurse home visit matter so much. Families can't recall every item they've brought because sometimes families just can't remember everything in their household. And sometimes the danger is hiding in plain sight in their American kitchen. Finally, let's talk about persistence, the kind that changes lives over time.
I am always giving a strong recommendation for vaccination for all children and families. Sometimes that includes multiple reminders. So we know that in order for kids to get into school, they need these vaccines. I remind families of that. I want your child to be vaccinated, not only because it's a requirement, but because I want your child to be protected against these vaccine preventable illnesses. I feel like most families are willing to vaccinate. They don't have hesitancy around it. The ones that do, I think that requires a special conversation. And the conversation really has to be curated around what that hesitancy is. Hesitancy in a Syrian family is very different than hesitancy in a Ukrainian family, and it's different than hesitancy in a family from a different part of the world. So what misinformation or hesitancy you're addressing is really important. And just getting them into care, making sure that we are offering vaccines, making them routine and easy for families to access so that they don't have to go very much out of their way to get this. And then reminding them that this is really a ticket into school in Washington State have been the top things that have really worked for me. And I think families are more willing to accept vaccines when they feel comfortable within the place that it's being offered. I always tell families, you can tell me no 1,000 times. If I think it's important, I will always check in with you. I will say, your child's 3 now. What do you think about speech therapy? I have families who come in who will be like, we're going to talk about vaccines again, aren't we? And I'm like, absolutely, every time, right? We're going to talk about speech therapy again. Absolutely, every time. So I think it's important. I'm not going to push you. I will respect your boundaries, but I think we should have an ongoing conversation. And many families at some point do warm up to it because they start to see, okay, I've put out these fires in my life. I have help in these sections of my life. Now I'm ready to focus on this. And I think we do them a disservice if we stop bringing things up because they've said no in the past.
This is the quote that stuck with me here. You can tell me no 1,000 times. If I think it's important, I'll always check in with you. This is truly a relationship, not a transaction. In a healthcare paradigm or world that feels so transactional, this is a gift if you're able to offer it to your patient. That father who's setting up barriers, the clinician sees past that resistance to the protection mechanism underneath. Sometimes saying no is the only control someone feels they have in a life that seems uncontrollable. How can you honor that and still move forward? and make the impact that you want to. I learned a lot through these clips and hope you did too. These stories remind us that refugee healthcare isn't just about treating medical conditions. It's also about witnessing resilience, honoring journeys, and understanding that healing happens in the spaces between what we can measure, and we love measuring, and what we can feel. I hope some of this resonated with you and makes you a better clinician or a healthcare leader designing systems that's better for our communities. Until next time, keep listening, really listening, not just to this podcast, but to the stories of your patients and the stories that they're telling you.
As always, thank you for listening to Healthcare for Humans. If you've found any value in this podcast, I have 2 quick requests. 1, please leave a review in the podcast app that you're listening to my voice in right now. It really helps others discover the show. 2, share this episode with anyone who you think might benefit from it. For easy access to all our episodes and to support the podcast, visit www.healthcareforhumans.org. There you'll find our content clearly organized by topics, countries, themes, to help you choose what to listen to next. Until next time, this is Dr. Raj Sundar, reminding you that culturally responsive care leads to better patient outcomes. See you again soon.